for robotic versus laparoscopic Whipple. So first of all, thank you for having me. All right, so I was an intuitive proctor pre-COVID, so it's getting to be a long time ago since a lot of us have been out, but that is my disclosure. So when you think about robot and laparoscopic Whipple, I'll kind of split this into 4 little sections to talk about. We'll talk about outcomes and what data there is or the lack of data, the utilization and training, some of the less scientific but I think important differences in these 2 modalities, and then of course we have to talk about cost when we're talking about these 2 modalities. So several years ago, there was a group that put together a consensus statement on robotic pancreas surgery. And basically, when they talked about Whipple, we said that, there's really not enough data at that point to say that robot versus open, that robot was better than open. But they didn't specifically look at robot versus lap. There have been a couple of other studies, randomized studies that look at robot versus open, but no head-to-head data in robot versus lap. In the robot versus open studies, Leopard 2 trial, people like to split out and use that as a reason to not do robot. But actually, there was only 5 robotic procedures in that study and 40-some laparoscopic. So that's not real good data, again, to argue for or against robotic surgery. When looking specifically at the question of robot versus lap, there's really a paucity of data. There's this retrospective analysis from Dr. Minter's group looking at NISQIP data that basically said that the outcomes are pretty equivalent and there's less conversion. And you'll kind of see that trend through most studies, and you could see that with the robotic distal and lap distal too, that the conversion to open tends to be less with all robotic procedures. There's also a systematic review and meta-analysis, and we'll look at this a little bit closer, and this is between robot and lap. If you look at their complications, they're pretty similar, so around 40% for both modalities. The operative time was similar in this study. Delayed gastric emptying was similar. There was no difference in blood loss, and the fistula rates, all grades were also very similar. So in many of our important factors were the same with lap versus robot. But again, the thing that sticks out in almost all of these studies that the conversion to open is much less with robotic surgery. So 12% versus 26%. And, anecdotally, many of us can, surmise why that might be true. We have lots more abilities to suture and things like that with the robot. So we might be more willing to persist robotically than laparoscopically. When it comes to the trends, so what's happening across the country, and Dr. Zarakat put this nicely that surgeons are voting with their feet, and you can see this very nicely in this graph. This is unpublished data from Dr. Pitt's group that's just submitted, and if you look at the overall, the MIS overall, the robot and lap, the overall percentage went from 7 to 11%. So we're increasingly doing Whipples minimally invasive. But if you compare the robot and the lap, the laparoscopic numbers are actually going down. So from just above 4% to down below 3%, and the robot numbers are growing. So the robot numbers have went up from 3.5% or so to up to 7.5%. So the robotic numbers are growing quite nicely. And when you look at conversion rates, this again, it holds true that you look at the lap conversion rates over this time. So the left-hand graph is 2014, and on your right is 2019. So over those 5 years, the laparoscopic rate of conversion actually went up to nearly 40%, whereas the robotic conversion stayed about the same at 15%. So again, a significant difference in the conversion rates between these 2 modalities. The length of stay in this study for open and laparoscopic was actually the same, with a length of stay near 11 days, and the robotic length of stay was closer to 9.5 days, which are statistically different from the lap. The morbidity rates over time, the open risk of morbidity was around 35% and actually went up over that course of 5 years. And for robot, went down significantly. And you can imagine as people get more experience in the quantity of robotic Whipples is increasing, that people are getting probably more facile at this operation, and the complications are decreasing somewhat. when we look at the ability to learn this procedure and make, a program that is everlasting and that can be done at many hospitals across the country, this is our data from our group. So when we learned robotic Whipple many years ago, we really went about this in a very thoughtful, prescribed way. So we went and watched several different surgeons. We went to Pittsburgh, we went to Dr. Martini, we practiced in the lab, we used biotissue, we had them grade us on it. So we really knew by the time we started this operation that we had the skills to do it. So when starting these programs in a very thoughtful way, I think we could show that you can do this safely and that the learning curve can be mitigated somewhat. So when we looked at our first 30 and matched them to 60 open, you can see it was slower, which is pretty similar across many studies. But all the other major complications, the fistula rates, the DGE, the length of stays, were all similar between our robotic and open. In this study, when we looked at just the first 30, the 30-day readmission rate was higher, and that has since then has evened out to not be significant any longer. And this is our time, so you can see our learning curve, or you can see as in that first 10 that our times dropped dramatically, and then that next 20, then they really just hovered about the same. And so you can see that that first 10 was really the important part of our learning curve. All right, so less scientific but important advantages. This is where I wish I probably should have taken debate class. I'll see if Dr. Kendrick took debate class in high school. So the other things that are less scientific but important, so ergonomics, and I'll talk about this in 1 second. The other things, though, that improved instrument dexterity, our ability to suture with robot versus lap is definitely easier. The 3D visualization and the camera stability. I think many of us that use the robot a lot now and then go back to use a lap and even do a simple laparoscopic procedure like a lap chole, when you don't have control of the camera and it's moving all around and you're trying to get, a student or assistant to point to the, in the proper area, that gets a little frustrating to not have control over that. So I think there's a lot of advantages that are less easy to parse out with data. Thank you. So ergonomics. So this is there's no studies looking head to head, but in general, as we do these longer procedures, the effects on our body are important. So, standing with our arms extended or in our head, extended is not very good for us in the long term. And so to move this along, there are ways that people are trying to minimize this for laparoscopic with these, chairs and things, but this is not widely accepted. So overall, I would say that, the robot, although not the perfect answer, sitting comfortably in a position with your hands at your side is good. For cost, for the most part, there's not studies looking head-to-head lap versus robot, but this is Pittsburgh's data looking at their lap versus open, and when they combine this with ERAS, their robotic cost has actually gotten less than their open cost. So you can see $20,000 versus $22,000. So the best argument, and this is probably the biggest argument I can make, is that most of us mere mortal surgeons aren't as technically gifted as probably Dr. Kendrick is and a few others in the country that have really been able to make these robotic or laparoscopic programs. And so I think, as you can see with the numbers, as people really pick up on robot, that laparoscopic number is dropping, because for the most surgeons, their laparoscopic skills aren't good enough to do it. So for me, pretty easy answer that I'll pick the left over the right any day. Thank you.